Thank you. Thanks, Lisa. Well, I'm really happy to get to be here with you all this morning. I'm coming to you from Portland, Oregon, where it is just a gorgeous day, although you can't, no way to tell because you're seeing me sitting in my basement where I have been working for the last 14, 16 months, half my time working from home, which is part of why we're going to be talking about delivering care through telemedicine today. I will mention that right above me, I can hear right now my dog is walking around, and she's going to probably even go for a walk here. If we'll find out if any packages get delivered, because you'll hear she'll go berserk. But I'll apologize for any of those noises or strange sounds up front. A little bit about me really quickly. I'm a family doctor here in Portland, Oregon. I work at Oregon Health and Science University, where I teach medical students and residents. And I care for a patient panel at a federally qualified health center clinic here in Portland, where basically 100% of my patients are Medicaid and Medicare funded. I've been doing that for about 16 years. And it's been fantastic. For the last well, during the entire pandemic, I've been doing half of my clinical care from right where I'm sitting right now, my basement. So the way we're doing it has been 1 week working from home, then a week in the clinic. So I have a lot of experience in telemedicine personally, which I'll be trying to share with you here today. I also attend on our inpatient service at the University Hospital about a week every other month or so. That's about half my time is clinical work. The rest of my time I spend teaching about and researching how to teach healthcare professionals to be clear communicators with their patients and their clients. And so a lot of my work around health literacy is going to come to bear in our talk this morning. Just logistically speaking, it doesn't look like folks have their cameras on, which is good. I think from a streaming standpoint, we're going to be talking about problems with broadband internet as a way of delivering care. And we'll keep your cameras off during the presentation today. That may help some of us if we're having streaming difficulties. Also, remember to keep your microphones muted. I'm going to ask you to hold questions until the end, and we'll try to reserve about a half an hour at the end for a conversation. If you put questions or comments in the chat box, I'm not going to be able to monitor those, although Lisa and Karen may be able to help keep track of those, and we'll save them to the end again. 2 hours is a long time to be sitting, so I'm going to make sure that we build in at least a 5-minute break in the middle here. So if you need time to get up and stretch your legs and get a drink of water or something, we'll do that. And then just 2 caveats about the talk this morning. First being that we're talking about the title is telemedicine, which really implies that we're talking about healthcare delivery. But everything that we're talking about today is equally relevant to social service delivery. So I want to just make sure that we make that obvious and clear. And then the second piece is that the talk this morning is framed around providing services for older adults. But again, everything that we're going to be talking about is equally relevant to all ages. So just to keep that in mind. I'm going to now share my screen and get us started here. And Lisa or Karen, can you tell me if you're seeing the slides or if you're seeing something else?
We're seeing your view. It's not in slideshow.
How's that?
Perfect.
Great. All right. Okay. So first off, I don't have any conflicts to disclose. Here's the I'll call the arc of the story, where we're going to go this morning. We're talking about specifically an older adult population who and many of us are aware, have the highest burden of chronic disease. Also, the highest utilization of health services of any segment of the population, but in addition have lowest rates of health literacy, and also have a variety of other barriers that are going to make telemedicine more challenging, specifically sensory barriers like hearing impairment or visual impairments. We'll be talking then about what are some of the clear communication practices that we can use to help mitigate these issues for this specific population. The objectives for the session are two. One is to discuss how telemedicine could and can exacerbate healthcare inequities for people with lower health literacy, and in this case, older adults, and then describe some best practices for spoken communication to help us overcome those challenges. What I'm not going to be talking about are things like telemedicine laws and regulations, how to set up a system, the technical specifications about how this all works, and the billing issues behind that. Basically, we're going to be talking about the interaction between one person and another person via either telephone or two-way video, and all of the sort of magic in the background that makes that possible, we're going to be leaving out. So the outline will look like this. We'll talk a bit about some of just the epidemiology or the statistics around health literacy in older adults. We'll talk about other specific communication challenges for this population and how those interact with health literacy. Then kind of hone in on telemedicine specifically and what are some of the real benefits that it offers, but what are some of the challenges that we need to figure out how to get around as well. I'll try to make sure that we're maintaining an equity lens as we're talking through this, and we'll actually have a section specific about equity for older adults. And then we'll get into some real practical tips for how to make telemedicine encounters go smoothly. And then lastly, we'll get into about half of the session will be focusing in on a series of best practices and how they look and play out across either telephone or two-way video encounters. And again, we'll save some time at the end for discussion. So if questions or comments are coming up, please jot those down so that we can have a conversation at the end. All right, so health literacy in older adults. First off, I'm going to use a newer definition, maybe one that you may not be familiar with, that came out just at the end of 2020 as part of the Healthy People 2030 initiative from Department of Health and Human Services. So for the first time now, we have a definition that provides us with a definition for patients and clients. We'll call that personal health literacy, which is really an individual's ability to get information in and use it. And that's similar to old definitions that you're probably familiar with. And now for the first time, we really have a second definition, which is around organizational health literacy and or the agents of organizations, which is us. People working in healthcare or social services are the agents of organizations. And we can now start to define or find ourselves defined in a role around our ability to deliver equitable, understandable, and usable health and social service information to patients and clients. So you may be familiar with this if you've participated in the other sessions in this series, but we have a really huge health literacy problem in the United States. And these data are from the National Assessment of Adult Literacy, showing that in the red box area there, that about 36% of US adults have low health literacy at the baseline, as their starting point. So what you'll see there is you see in that top purple bar, 14% with below basic skills, and 22% with basic skills. You put those together, that's that 36%. And those are really considered skills that are inadequate for coping with the typical types of information that patients and clients receive when they come, when they interact with healthcare and social service agencies. Now that's a baseline. So that's in the kind of, these are people being tested in the comfort of their own home under their best test scenario, best environment. When you put people into healthcare or social service environments where there's stress, where they're not feeling well, where they're having pain, if they're worried about what you're going to be talking about, there's other distractions, then those people's health literacy will kind of go down in those environments as well. And I'll come back to this as we move on this morning. This slide's a little small, hard to see here, but basically what the top bars in blue are showing that by one measure in the United States, about 52% of the population has low literacy skills in general. And then comparing that to numeracy skills, which is the green bars below that, which are even worse in the United States. Numeracy is the ability to use basic numbers and math in conversation. So what we're seeing here is that while half of US adults have low literacy skills, almost 2/3 of US adults have low numeracy skills. And numeracy is critical in virtually every single medical or healthcare encounter. Every time we're talking about prescriptions or many other parts of medical encounters involve numbers and math. So we've got these barriers to deal with. Now these are for all ages. When we break it down now by age, we start to see that the situation is looking quite a bit worse, in fact. So again, these are from the National Assessment of Adult Literacy. And these numbers have been pretty stable over decades now. But you can see on the left-hand side here that for age 65 and older, that population has the lowest health literacy scores of any age group in the United States. And then if we look at it by percentages, whereas 36% of all ages have low health literacy, amongst 65 and older, it's like almost 60% have inadequate health literacy at baseline. In addition, older adults have quite a few other barriers and challenges that we need to take into consideration here, which are going to interact with health literacy skills. So let's talk a bit about telemedicine first, and then we'll talk about some of those barriers and challenges. So telemedicine, we're going to just define here as a healthcare that's delivered to patients at a distance using either telephone or two-way video, right? So the patient or the client and the service provider are in different places and are connecting through technology. And that is going to produce specific barriers that are going to be more likely to impact older adults. So think about this. So in the United States, disability is incredibly common. And one of the more common forms of disability are mobility issues. So telemedicine has the potential to be really helpful for people who have mobility issues, right? If it's hard for a person to leave their home or where they are and travel, for example, to a clinic or to an agency, the ability to do that by phone or by video can be a very important advantage for that population. Similarly, people who have difficulties with independent living may benefit for the same reasons, that if it's difficult to get out and get things and get places on your own, and you rely on others for help with that, the ability to do this by phone or by video can be a huge benefit. But there are some forms of disability for which telemedicine is going to produce challenges. So for people who are hearing impaired or deaf, there's going to be some obvious challenges that are not going to, we're not necessarily going to be able to work around very easily, although we're going to talk about some solutions as we go on. And for people who are visually impaired or blind, again, specifically around video encounters, will be some challenges there, or at least inability to benefit in the same ways that others might. Looking at the hearing loss issue a little more closely, this graphic really illustrates the fact that two important things. One, that hearing loss is incredibly common and becomes more and more common with age. So looking at the bottom row on this graphic, the age group of 50 to 59, about 6% of women have hearing impairments in that age group, and about 20% of men have hearing impairments in that age group. And you'll see this through each decade of life, that the rates of hearing impairment go up dramatically, and in that for every decade of life, men have quite a bit more hearing loss as a population than women do. But these numbers are really huge, and they're going to be incredibly important if we're trying to have conversations over telephone or by video. So hearing is going to be a really big one. Other barriers include access and use of internet. So in 2020, only about 75% of seniors said that they use the internet. 75% are using the internet. Whether they're using it in a skilled way or not, we don't know. But that compares to almost 100% of other age groups who are using the internet. So seniors are lagging in some ways as a population in terms of just access to internet services. Broadband internet, which is probably what we're using here to be able to hear me and see me today, is also going to be an important issue if a person's going to be using video, two-way video encounters. So almost 2/3 of US seniors say they have access to broadband at home, and that those numbers are quite a bit higher for other age groups. So there's going to be some barriers. Many of our seniors are not going to have adequate access to internet or broadband internet to be able to utilize video conferencing calls or encounters, and we'll be more likely to need to use telephone instead. Then we can think about language issues. About 1 out of 5 US adults speak a language other than English at home. And so we'll have to consider how we're going to be able to provide language interpretation services by phone and by video. And we'll talk more about that as we go on this morning. All right, so let's move into some of the pros and cons of using phone or video encounters. I think the pandemic really set this ball in motion. Prior to that, a year and a half ago, I never did phone encounters or video encounters. I certainly spent time on the phone with people, but those were not reimbursed, and they weren't true medical encounters in that same sense. This graph is showing up until March of 2020, so more than a year ago, actually. You can start to see how telemedicine use was really taking off, corresponding with kind of needs of the pandemic. And then I think if we were to track that data forward, we would see that the use of telemedicine has really exploded in the years since then. So let's look at just some of the pros and cons here in more detail to help us think about how we're going to be able to deliver clear communication. Starting with the phone. Clearly some great benefits to being able to have an encounter with a patient or a client by phone. Some of these include just straight convenience. So many patients of mine, and many patients report this in the literature, that it's difficult to come to clinic-based appointments because of other responsibilities. So we've got caregiving responsibilities. If a person is caring for younger people or caring for older people in the home, and are concerned about leaving those people, those are barriers for being able to come in and have an office-based visit. Similarly, many people have a hard time getting away from their jobs to get to office-based visits. So the phone can be a really important way of accessing health and social services that might not have existed prior. We've mentioned mobility issues already. People with mobility problems, people who have trouble walking, for example, being able to have an encounter by phone is going to be an incredible advantage frequently. I have many patients who try to avoid coming to the clinic because it's either painful, hard to do, hard to walk, or have things like incontinence, which makes them nervous about leaving the house or having to travel and having to wait in the waiting areas and things like that. So there's some advantages to being able to do this by phone or video for sure. There's cost advantages. Many of my patients will tell me that just the cost of gasoline to get to the clinic for an appointment is often a burden, and to be able to avoid that can be a great benefit. Of course, you have to consider there may be some other costs on the other end. If you're having to think about paying for phone service or paying for internet service, those are other maybe hidden costs. But the cost of travel is certainly a benefit. Many of my patients travel by bus or taxi or ride sharing services like Uber or Lyft. And so we can offer real benefits by not having to have them come in all the time. And then when we're doing encounters by phone, it may be easier for that person to have someone else there with them. If there's another family member who they live with, that person may be able to join us for a phone conversation where it might be harder for that person to get away and come to a clinic appointment with the patient. We'll talk more about that. Some real barriers though. So first off, a lot of my patients don't have reliable phone service. So I have many patients whose phone numbers change, who go for periods of time without paying bills and losing phone service. So reliable phone access can be an issue. Then there's the variability of the connections. So I've had many appointments and visits over the phone where we had trouble either hearing each other or where the connection was cutting in and out and information was being dropped. And that's a huge problem. And it makes me worry about medical errors if I'm not 100% sure that I'm getting the information clearly. Obviously, there's going to be some concerns for folks who are deaf or hearing impaired, and we may be able to get around some of those through things like captioning services or captioning telephones, which I'll talk about more in a little bit. One huge issue with the phone, though, is the loss of nonverbal communication. So there's been almost no research in this area, but I can tell you just from my own experience that phone and video visits, but phone visits in particular, have been really challenging for me because what I've noticed is that me and whoever I'm talking with have a hard time knowing when the other person has finished talking. And so there's been a lot of interrupting and talking over each other. And it's very disruptive and really interferes with the flow of the conversation. And in fact, whole ideas of kind of get missed or set aside when we have to fumble over whose turn it is to talk. I don't really know a way around this, but I've noticed it a lot with phone as well as with video. And then the last barrier here for phone we'll talk about will be just the potential loss of privacy. So for many of our patients and clients, there's a real advantage about being able to come into a clinic and come and into an examination room behind a closed door by yourself and be alone with your provider or whoever you're working with. We might lose that in this environment, and we may have patients and clients who are sitting at home who have other people around them who are listening in or could listen in, and that could be a problem, particularly if the issues that need to be discussed involve that other person, for example. We'll talk more about privacy in a minute. Let's move over to video and think about some of the advantages there. We've got all the same advantages when we're doing two-way video that we have with telephone, the convenience and the mobility issues, the cost savings. But there's more. There are other advantages when video is involved. So, for example, I can use video encounters to visually assess a person in some ways. I can see how sick does this person look, for example. I can look at skin findings. There's other things though that are really, really valuable to me. I can ask a patient to show me their pill bottle or show me all their pill bottles. And I can have them demonstrate for me or show me how they're taking a medication, right? Show me how you're using your asthma inhaler. So there's some great advantages to video in that sense from a medical standpoint. You get back a little bit of the nonverbal communication. I can get a sense of what a person's affect looks like, and I can tell if they seem to be appreciating what we're talking about or not. But again, I've noticed with video, the same kind of thing with phone is that we're talking over each other a lot. There's some missed cues there about when a person's done talking and when the next person's turn starts that I haven't figured out how to get around yet. Now, in terms of barriers, same barriers as for phone use, right? There's connectivity problems and there's access and equity issues to be considered. But there's also the issue of familiarity with the technology. So you may be familiar with this notion of the digital divide and this idea that older adults have less necessarily skills needed to make things that are more technologically based work well. And I've certainly seen this in my patients that many of my older patients have become really frustrated with trying to use two-way video calls and have reverted back to phone only. So we've lost a little bit of those advantages. There's going to be certainly issues for people who are blind or visually impaired when we're trying to use video that we can't get around. So let's talk more about some equity concerns then that are specific to an older population. And maybe this will be a framing of the issue in a way that you might not have necessarily thought of it before. But I'm going to propose an idea around systemic ageism. This is a topic that does not get a lot of attention, at least in my area of work. But we could define systemic ageism as a situation where a policy or practice that's the same for everyone has an unfair advantage or unfair effect on someone because of their age. All right, so it may advantage some folks because of age or disadvantage others based on age. So let me show you kind of a graphic that I use to help me think about this. We think about our healthcare system right now is producing massive amounts of unnecessarily complicated health information. And that's kind of our default is producing information that's confusing, right? All of our patients, all clients always tell us that the health information they're receiving is confusing. And that's generally not necessary. We could make things clearer. We just haven't necessarily had the will to do that yet. We think about, so the system is churning out complicated health information. At the same time, we've already been discussing some of these barriers for older adults and some of the limitations of telemedicine. And those are going to interact with this complexity in such a way that it's going to produce some unfair advantages for folks who have higher health literacy skills, who are, and those are going to tend to be younger and more socially and economically advantaged individuals, right? So there's going to be unfair advantage in some ways for some folks. There's going to be some restriction opportunities for folks who have lower health literacy. And as we've been talking about, that is going to tend to be disproportionately affecting older adults, who also are going to be disproportionately affected by these other sensory impairments like hearing and vision loss, right? So now we've got unfair advantage for some, unfair disadvantage for others based on age, and there's our definition of systemic ageism. So the system is going to be set up to promote this outcome, systemic ageism, right? The system is not going to be built to benefit older adults first. The way it is right now, the system is built, and we're trying to figure out how to accommodate older adults in that system, but it's not designed specifically for that community. Part of the concern and complexity involved in this is this notion of intersectionality, which is how different aspects of a person's life and situation interact and interplay together to create additional barriers to clear communication, and especially when we're thinking about clear communication in a telemedicine environment. So let me just show you some of the things that I think are contributing to the complexity here in this intersectionality. We've got age and ageism, educational differences, which lead to health literacy differences, language differences, hearing and vision impairment, systemic racism, differences in income and insurance coverage, and regional access to broadband internet. These are just some of the barriers, some of the issues that are going to create complexity and added difficulties for the communities that we're trying to help care for. So that's kind of putting it into some context for us. Now let's kind of just think about how do we start to apply this to some solutions, right? So I'm going to now go into 4 or 5 slides that are basically going to be long lists of tips for how to make telemedicine encounters go as smoothly as possible and help benefit patients and clients maximally. So I apologize for kind of the long sets of lists here, but you'll have these to refer back to if you need to. So here's a picture of a colleague of mine. This is Dr. Laura Byerly, who's one of the physicians here at Oregon Health and Science University, and she and I work closely together teaching medical students. This is a picture of her having a telemedicine encounter or virtual encounter with a patient. You can see her, she's sitting in an office space. She's got her laptop there, which has the webcam on it. So she's got a video of the patient in front of her. And then behind that, she's got a larger monitor, a screen, where she's going to be able to access this patient's electronic health record. And she'll be typing in her notes and putting in orders for whatever she's trying to do there. You may not be able to tell, but she also has headphones that she's using to help her listen to the patient, which can also provide a little bit of privacy so that whatever the patient is being said is going into the headphones, is not going out into the room where there might be other providers. So now let's think about how to make one of these encounters go well. So these are going to be some tips. So even before the encounter starts, there are a whole bunch of things that we can be doing to prepare prior to the encounter to make sure that things go smoothly. And some of this is things that the person who's going to be engaging in the encounter will be doing, and some of them are things that other members of the team are are going to be taken care of. So when we're making appointments for either a video or a phone encounter, making sure we have the patient's best phone number and a backup number. So many times I'm making my call to during my appointed time, I'm making the call to the patient and the phone number is not going through. And I'm finding out later that patient's phone number changed and we didn't have that updated. And I didn't have a backup number to call. Confirming the person's preferred language and arranging for a professional interpretation has to be done in advance. It's very challenging to try to do that in the moment. So a day or two prior to the appointment, if we're trying to set up language services, those are things that need to be done behind the scenes to make them go smoothly. If a person is hearing impaired or deaf, and we're trying to arrange for either a sign language interpreter for a video visit, or if the person has a phone that allows them to have captioning, which is where a person is typing in words on a screen, then those also need to be set up in advance. And those are very hard. In our system, we're not able to set those up in the moment. We have to set those up in advance. So we've got to be thinking ahead as we're scheduling. If possible, when we're setting up these two-way video visits, what we've noticed in our group is that a lot of our patients, the first 1, 2, or 3 times that we are trying to do one of these visits, they have a lot of problems, technical problems. And so what we've noticed is that people will think that they're all set up and ready to go, and then the time of the encounter comes along, and I'm sitting waiting in the video chat room, and the patient is not connecting on their end. And so then we're getting on the phone with them, calling and saying, what's going on? Can we talk you through this? Really helpful to be able to do a dry run or a practice run before the first encounter with folks. Remember, the technology is changing. If people are changing if they're doing this on their phones are constantly changing. And so the apps are changing, all these things. So it's very helpful to be able to talk a person through it and actually run them through it first. Always good to have a backup plan. So I'd always try to make sure my patients know, what am we going to do if this doesn't work? Typically, that means I'm going to call you and we'll talk over the phone if it was going to be a video visit. Having that in advance and knowing what to do is helpful so that it doesn't just end up being a missed appointment and patient wondering what to do. Continuing with still before the encounter, it's really helpful to get patients and clients to prepare for these visits, right? Ask them to have a list of their concerns already written out and ready to go. We should be doing this for all kinds of appointments, even clinic-based appointments. But in my experience, we tend to not remind people to do this very often. So this is a good opportunity to try to remind folks to do that as they're setting up these appointments. Ask people to gather any data that we might want to use in advance. So if a person's weight is important for us to know, if maybe we're tracking heart failure symptoms, we want to ask that person, get your weight before the video visit starts or before the phone visit starts. If you have a blood pressure cuff at home, which now many people do in the time of the pandemic, we've been sending out blood pressure cuffs to people at home. Check your blood pressure for me before we start the visit so that I can have that information when we get started. If you're doing a diabetes follow-up, poke your finger and check your blood sugar before the visit so that we can use that information. Ask people to have their medications nearby where they're going to be having their encounters so that if we have questions or need to talk about medication use, they can either show us the pill bottles or they can pick it up and describe it to us over the phone. Making sure that phones or whatever tablets or whatever the person is using are adequately charged. This comes up for me when I'm in clinic where my clinic computers don't have webcams on them and I'm having to use my phone for video encounters. And if I haven't been paying attention and I've let my battery run down, then I have problems maintaining the length of the visit. And I've had a couple of occasions where I had to end a visit because I didn't have, because my phone died. But patients have the same problem. And so they need to be plugged in or charged on their end as well, and reminding them to do that. It's really helpful to be able to write things out for people. So I like to keep a pad of paper or a dry erase board near me so that I can write on it and hold it up to the screen and show the person something. So very frequently, I'm logging into a video encounter with someone and I can see them, but I can't hear them. And they're either muted or there's a problem with the connectivity. So I oftentimes, or they can't hear me. So I might be writing on the thing, I can't hear you, you can't hear me. Try logging out and logging back in, something like that. So be able to write a sign for people. It's also a way that we can write out things that we want people to be able to see how it's spelled. So like the name of a medication, perhaps I might write that out on a dry erase board or a piece of paper and hold it up for the person so they can see the spelling. Or write out a phone number that I want somebody to have, hold that up for them. So having that available is important. And then the last one, this is kind of just a style issue, is about where do you place your camera? And many of us have been taught when we're interacting with a patient in an office visit to make sure that we sit down, and so that we're at eye level with our patient or even below eye level, as a way of kind of diffusing some of that power differential in the room. And just being more personal with a person. It doesn't feel great to have someone standing up over you, talking down to you. Well, I think we can create some of that here with our webcams as well. And so right now I have my webcam is kind of at eye level for me, but I frequently see people looking down at their cameras. And when you're the patient or the client on your end, that's you looking up at the person talking to you. So just a style issue there. Let's switch to concerns about privacy, which are really pretty important and are kind of open this whole new set of issues now that we're doing these virtual visits. Both of us, both the patient client and the professional should make sure that they have a quiet, private space to talk. I had a visit yesterday with a patient of mine who, it was a phone visit. And when I called him, the first thing I ask is, are you at home or are you somewhere else? And he told me that he was at his dentist's office. And so I had to have a conversation with him about, is this going to be a place where we can talk privately and you're not going to be sharing, personal information with the other people in the waiting area? And that conversation took a long time, and eventually he wasn't concerned about it, but I was concerned. And so we kind of ended up doing a short and truncated visit because I didn't feel comfortable talking with him about the issues that he wanted to talk about with him speaking openly in a public space. And so we made arrangements to talk again later. Sometimes we're doing these visits in clinical spaces. So sometimes I'm doing this from my clinic office, where there may be other providers in the same room. Maybe they're having video or phone visits as well, and they may be visible behind me. And so I want to be able to position myself in such a way where patients who are talking with me or watching me on video aren't also seeing other providers behind me moving back and forth, and or seeing potentially private information about other patients or hearing anything about other patients. It's helpful, obviously, for me to turn up the volume so that I can hear and understand people, but we need to be cognizant of the fact that if I'm turning up the volume as loud as it goes to help me hear, that may be making it so that other people in the building can hear as well, and that can be a a significant privacy concern. Now that since we're not in the same room with the person and they can't probably see our name badge clearly, there's some issues around making sure that we've identified ourselves clearly. Identify yourself by your name, your role, and where you work. Patients and clients nowadays are interacting with lots of people via video and phone, and unless they have a well-established relationship with you, they may be confused about who you are and what services you're providing. Likewise, we need to now identify our patients. In a clinic environment, when I'm seeing patients, even if it's a person I've never met before, they're coming through the front office and they're checking in at the front desk where they're asking them to confirm their identity, checking on their insurance status, making sure their phone numbers are updated, all that stuff that happens at the front desk. But now by phone visits for me, I'm doing that myself. And so I need to make sure I've got the right person. So I'm using 2 patient identifiers like name and date of birth, for example. Really important to ask patients and clients, who else is with you? Who else is in the room or who's listening in on this conversation today, right? If we're talking to people at their home or place of work or somewhere else, there are likely other people who are in on the conversation. And we need to know who those people are so that we can make sure that we're having safe, private conversations and not exposing information to people who shouldn't be hearing it. Likewise, I'll always make sure I tell people, there's nobody else here in the room that I'm working from, or if I'm working with other providers, yes, there are other providers in this room, and I'm going to use a headset so that what you tell me is private, for example. And that's that idea of headsets there. Hearing issues, we've already alluded to the fact that these are going to be incredibly important in this environment. Some ways to help with that: minimizing the background noises. That's hard to do when I'm working from the clinic environment where there's other people, other things happening. So I'm usually trying to find an exam room where I can go in and close the door and be alone, but that doesn't always happen. When I'm working at home, I have to do things like perhaps like turn off the furnace so the heat, because I'm working from the basement where the furnace is. And when that thing comes on, there's a loud humming noise that can make it hard for people to hear me. So minimizing that. Using a headset is helpful for me to be able to hear better. And again, that helps promote a little bit of privacy. And then checking in with patients. How is my voice coming through to you? Are you missing any of this? Is it coming through clearly or not? Some of my patients have difficulties with certain tones of voice. Some have like lower tones, like my voice can be harder for some people to hear and easier for others. So checking in on that is helpful. And patients often won't mention it unless you ask. Making sure that we're offering sign language interpretation or captioning services. So captioning services are fairly new to me. Since the start of the pandemic is when we've really started using them in our clinic. And these are services where I can connect with a third party who's a captioner, a person who's going to type the conversation. So everything that I say can be typed onto the screen, and the person that I'm working with can read it if they need to. If they're hearing impaired, they may be listening to me, but having the backup of the written conversation in case they feel like they missed something. And that can be helpful. It's a little bit challenging sometimes to set up. And as I mentioned earlier, it doesn't work for on-the-fly appointments. It needs to be set up in advance. All right. Memory aids. These are ideas that have been around for a long time, using memory aids to help people. But in this environment, this is really helpful, right? Reminding people to take some notes while we're talking. I don't think we remind people that enough. It's always been suggested that patients come in and take notes during office visits, which in my experience is pretty rare. But here, when we have a person at home or at work, where they're listening, where we're talking on the phone or by video, there's often a better opportunity to say, hey, why don't you grab a notebook or a piece of paper and a pencil and have it ready for you so you can take some notes while we talk. Encouraging people to have another person with them, if that's going to be appropriate for the conversation. Many times it's very helpful to have a family member who helps provide support be there for a visit, to help be a second set of ears, to help provide additional history. And so in those situations where it's appropriate to have another person there, it may be easier to do that when we're working remotely like this. And then the written visit summary. So in the clinic, it's very important to be able to provide people with a written summary of what's happened, right? The high points of the encounter. And we call those the after visit summary. We print that out and send it home with people. And that's a really important tool when it's used properly as a memory aid for when the person gets home and can't remember the important things that we talked about. But when we're working by video or by phone, we sort of lose that tool or we forget about it often. Now, for me, if I'm working with someone on a video call, that means that person has logged in through their private patient portal, which is a secure portal where they can get into their medical record, look at some things like lab results and stuff like that. That's how we connect by video in our system here, is through that portal. So if a person's interacting with me by video, that means they have access to their patient portal. And then I can put a written summary in that and they can access it there. So that I'll have to orient them to that fact that I'm typing some notes in here that's going to be a summary of what we've talked about in case you want to go back and refer to that later. When we're working by phone, we don't really have that advantage. And so to overcome that, we might have to just do a little bit of a workaround. For example, we might need to figure out how to fax a written summary, which I can certainly do from my electronic medical record. I can have one of my team assistants fax the visit summary to the patient or mail it through the mail. Easy enough to do. But remembering to do that might be a bigger barrier. So those are some thoughts to keep in mind. Let's move on to now some clear communication best practices. I'm going to go through the first one of these, and then we're going to take a 5-minute break. So these are best practices are based on some consensus work studies that I was involved in several years ago, where we were really trying to identify a list. What are the best practices for clear communication? We know that low health literacy is a huge issue. What are the things that us as healthcare and social service providers can be doing to mitigate or minimize trouble understanding, right? So what are those clear communication best practices? And this paper that I'm showing you here was a second study where we were trying to come up with a list of things that healthcare professionals can do and then prioritize them, rank order them in terms of most importance. So these are known best practices and they're pretty, I would say, widely accepted. Most of them are based on expert opinion, and there's not been a whole lot of empirical research to support many of these items, but there's a strong consensus amongst health literacy professionals in the US around these issues in general, I would say. So I'm not going to show you that list yet, but we took that list of best practices, and then more recently I've tried to apply those to this context that we're talking about today, which is how do these best practices play out in a telemedicine world? And so this paper is one that that I wrote late last year, trying to adapt these best practices into this new environment for us. And this is what I've been talking about so far. So, so taking us back now to that definition where we defined personal health literacy for the patient and their ability to take in information and use it on the left-hand side of the graphic here. And then the organizational health literacy on the right-hand side, and noticing that the organizational information flow is shown as a bigger arrow here, designed to represent the fact that we are continuously overwhelming people with information. And as organizations and as agents of organizations, our job is to be trying to shrink that arrow and make things more understandable and clearer, easier to understand. So this idea of clear communication, simply defined as communication which helps people understand and act on health information. It's as simple as that. And so I'm going to show you now a series of best practices that support this. So here's the list. I think there's 9 items on here, which seems like a lot. We're going to go through them one at a time. And so we'll start with this first one, which is following a health literacy universal precautions approach. And I'll explain what that means if you're not familiar with that notion. So going back to a slide that we looked at earlier, where we talked about how 36% of US adults have low health literacy right off the bat, right? In the best case scenario at their baseline. And then I mentioned that that really, if a person is sick, scared, hurt, sleep deprived, or stressed, any of us are at risk for low health literacy in those situations. And so basically, any person who's coming into a healthcare environment for any services is likely to have lower health literacy than they might otherwise have at home. And we have to assume that all of us, everyone, is at risk for misunderstanding or not understanding their healthcare related information when they come to see us. On top of that, studies show that patients don't want us necessarily to know when they don't understand, because it creates a strong sense of shame. And so patients will actually go to great lengths to make it appear as if they're understanding us. And in fact, a series of studies have shown that patients are so good at this that healthcare professionals can't tell by looking. In other words, during the course of a typical office visit encounter, a conversation that would happen in any kind of medical or social service encounter, we are really unable to detect when people are understanding us well or not understanding us well through those typical kinds of interactions. Because of this, a lot of people have promoted this idea of screening for low health literacy over the years. There was really a fairly strong consensus that screening is not appropriate, and we can't really use that in a clinical environment. So, and I won't go into the details of necessarily why that is. We could talk about that in the at the end if people are interested in hearing more about that. Well, that brings us to this idea of universal precautions. So assuming that everyone's at risk at all the time, and that we can't tell who's understanding, who's not, we have to behave in a way that makes messaging as clear as possible every single time. This is in contrast to what we often see in practice, which is healthcare professionals and social service providers kind of modulating their communication based on what they think a patient's communication skill level is. So providing more complicated information to certain people and less complicated information to other people based on what we think we know about a person's socioeconomic status, education, and things like that. And it just turns out that that's not going to be an accurate, appropriate way to try to deliver equitable information. What we really need to do is learn how to provide those clearest, simplest messages, which is a skill that's very difficult to attain. But take complex information, distill it down into the simplest form, and deliver that to everybody every time as our default. That's the universal precautions approach. And then if patients want more information, they can get it. But we'd start with the simplest. So at this point, invariably people say, well, you know what, I work with a, I work with a highly literate, highly educated, high socioeconomic status population, and won't my patients be offended if I quote unquote dumb it down for them? And so the available studies suggest that no, that will not be a concern. In fact, everybody, regardless of literacy skills, regardless of their education and their socioeconomic status, everybody prefers clear communication. Everyone wants their health information to be delivered in the simplest, most easy to understand, easy to act on messaging. And if a person wants more detail after that, great. We're prepared to give that to them, but that's not where we start. So that's the end of, so that's the universal precautions approach. We do this same thing with everybody. We're gonna take a 5-minute break to stretch your legs and get a drink of water, whatever you need to do. And so at my time here in Oregon, it's 8:03, so it must be 11:03 Eastern time. We're gonna start back at 11:08 promptly. So feel free to take a break. I'll be starting back in exactly 5 minutes. Okay, it's 11:08 by my clock, so we'll get started back into it. All right, so moving on. So we've talked about universal precautions, treating everybody the same using the baseline clear communication practices. Now, what does that look like? How do we do that? So the rest of these best practices are the ways that we provide universal precautions. These are the practices that set up that universal precautions. First one is around use of medical interpreters, which might be a little bit surprising that I've listed that first. And I put this in here first because oftentimes this topic kind of gets pushed to the end as an afterthought. And I really think that this is one of those very few places in medicine and in social services where we can really see inequities playing out, where we can tell that if we're not using professional interpreters, we are directly contributing to inequities. So I put that up front. We've seen this slide already, that about 1 out of 5 people in the United States speak a language other than English at home, right? So this is a huge population, over 60 million people in the United States. And so language services are really, really important for us to pay attention to. By law in the US, if a healthcare organization is going to accept federal dollars, typically meaning Medicare and Medicaid dollars, they have to provide free interpreter services to patients and clients at every point of contact. What does that mean? It is interpreted a little bit differently from place to place. What these standards tell us, though, is that we should not be using family and friends as interpreters, which unfortunately, when we go out and watch what's happening in the world, we very frequently see that as the case. We see family members coming to appointments and acting as interpreters. And those are moments when we can basically say we're witnessing substandard communication occurring and errors playing out and inequities in care being delivered. So here's some of the data just quickly on the benefits of using professional interpreters versus what I'll call lay interpreters. Lay interpreters are using family or friends or even bilingual staff. So at my clinic, we have a lot of our providers speak a language other than English and love to do that with their patients, but they're not trained interpreters. They may be bilingual, but they may not be trained in interpreting language for other people. So here are some of the things we know. If we use a professional interpreter, we're going to have fewer communication errors. These are evidence-based outcomes. Fewer communication errors, better understanding. Patients and clients will understand the issues and the recommendations more clearly. Reduction of unnecessary testing. I saw a patient in clinic this week, a woman who spoke Vietnamese only, who was complaining of abdominal pain. And I was using a telephone Vietnamese interpreter. And we were really struggling to find a shared language around how to describe what was happening in her belly. And at the end, I wasn't confident in that I understood really what she was trying to describe for me. And I ended up ordering a CT scan or CAT scan of her belly to help make sure I wasn't missing something important, because I wasn't confident in the information I was receiving. And when we're using a lay interpreter, like a family or friends, the chances of us needing to use those technologies is much higher. And there's a lot of documented unnecessary waste related to that practice. Reduce risk of adverse events. So when we use a professional interpreters, people have better outcomes. They're more likely to adhere to their treatment plans. They, interestingly, have shorter lengths of stay in the hospital when we use professional interpreters. And really importantly, are much less likely to need to be readmitted to the hospital within 30 days of going home when professional interpreters are used. patients are more satisfied when we use professional interpreters, and there's a reduced risk of malpractice suits against us when we use professionals. Lots of good reasons. And I'll leave it at that. There's lots of people who don't use professional interpreters and who cite reasons like not having enough time or access. And I think we need to figure out ways around those. The next best practice on here though is upfront agenda setting. This topic is sometimes surprising for folks that this is a health literacy issue, but I think it really is. What are we talking about here? Upfront agenda setting is about figuring out what we're going to be talking about during the encounter. So in a primary care setting where I work, the typical patient comes with somewhere between 3 and 6 issues they want to have addressed. But interestingly, studies show that 50% of the time, their first thing that they mention as a concern is not their main concern, right? So it may say that person might have made an appointment and it says back pain on the appointment line for when they called in. I'm making an appointment. Yeah, I want to see the provider for my back pain. 50% of the time, that's not the real reason why they're coming in, or not their main concern. And in fact, 70% of the time, that's not the main concern if it's a mental health issue. So the important point here is to make sure that you get the whole list of concerns from the person at the beginning of the encounter, rather than following that first mentioned issue and getting a bunch of history about that, and then discovering later that they're also really concerned about something else. I've included a resource here. We're not going to look at this, but this is a link here to a training video that we use with our medical students, which illustrates a whole bunch of these clear communication best practices. And one of them is this agenda setting idea. So there's a little 3-minute segment in here that shows me doing a full agenda setting with an actor playing the part of a patient. And I invite you to take a look at that at some point if you're interested. Next one, and this is one we're going to spend some time on, is the use of plain language or avoiding unnecessary jargon. And this is a really big deal and really important when we're talking about phone and video encounters. So jargon, medical jargon, or social service jargon for that matter, is that specialized language that we use to communicate with our colleagues and to communicate with precision with each other. And that oftentimes spills over into our conversations with our patients and clients. So I'm actually gonna skip over. Actually, I'm not going to skip over this. This is a picture of a thing called the Rapid Estimate of Adult Literacy in Medicine. This is a research tool that we use in health literacy research to try to estimate a person's health literacy skills. And it's a really kind of clever, quick way to get a picture of a person's literacy skills. All it is a word list that you'd have a patient or have a research participant read out loud. There's 66 words on this list. You have them read it out loud. And it turns out that if a person does not pronounce a word correctly, then they tend to not have a working knowledge of that term, of that word. And so you're basically giving people a point for every word they pronounce correctly on this. And then correlation studies have linked scores on this to a person's grade level reading ability and other literacy skills. So, let me just give you like 20 seconds to just read down that first column on your own, just to yourself. You don't have to read this out loud, but just read through that first column and just see what the sense of some of these words are. Now, as we move through the columns, the words get a little bit longer, but they don't necessarily get more jargony or more complicated. What we're seeing here are, these are like the types of language that any patient can expect to encounter when they come into a healthcare environment. This is the flavor of the language that you're going to hear if you come to the clinic or the hospital. And these are not those really big, long, esoteric medical jargon terms. These are just the type of things that you're going to be confronted with. Now, the way we score this is kind of interesting and important. So if a person is only pronouncing somewhere between 0 and 18 of these words correctly, that's correlating with less than a 3rd grade reading level. If they're pronouncing 19 to 44 correctly, that correlates with a 4th to 6th grade reading level. If you're pronouncing 45 to 60 correctly, that correlates with a 7th to 8th grade reading level. And if you're pronouncing 61 to 66, remember there's only 66 items here, 61 to 66 correctly, you're someplace above a 9th grade reading level. Now this is important because in the United States, the average adult reads at an 8th grade reading level, which I'll show you here. So average adults reading at an 8th grade reading level. And we could infer from that that the average person who's coming to see us or talking to us on the phone or by video might not be familiar with somewhere between 5 and 20 of these particular words on this list, or these types of words, right? And so now you can start to imagine that these words are not that strange or unusual, and if the average person is not familiar with a sizable chunk of those, when they come to see us or talk with us, they may be missing a lot of the language because of jargon that we take for granted. I'm going to show just a 1-minute clip of some people on the streets of New York explaining their understanding of the word hypertension, which is a jargon term that we hear all the time. And let me link to that. So we have to go out, we have to link to this website to watch this. 1 minute here.
Hi, I'm Cassie.
And I'm Blair.
And today we're on the streets of New York interviewing people about their health literacy. Can you describe to me what hypertension is?
I'm guessing it's when you're really hypertense. I have no idea.
No, but it sounds bad.
I don't know that.
Hypertension would be overactiveness in the muscles.
So is it when you stress a muscle or something like that?
No, actually in the mind, maybe. Hypertension.
Hypertension is like a mental disorder.
I don't have it though.
To be treated with the proper medicine.
Hypertension would be overactive stressfulness.
I don't know.
All right. So, so hypertension, a word that's taken for granted in our hospitals and clinics all the time. A word that many people have heard but don't know the meaning of. And in this case, a lot of the people didn't have a clue what it represented at all. Just an example of how some of the language that becomes second nature in a healthcare environment is really unfamiliar to people otherwise. Now, jargon is really complicated. We're not going to get into the details of it, but I put this busy slide up to show you that people think a lot about jargon, and there's kind of 3 types. There's the technical stuff, like the word hypertension. But then there's also this thing called quantitative jargon, which I'm not really going to get into right now, but I do want to point out this idea about lay jargon. Lay jargon are terms that have one meaning inside a healthcare environment and a completely different meaning outside of healthcare. And these can be really confusing. So for example, you see here under lay words, the term stable. So it's really common in our healthcare environments to hear healthcare providers telling patients, oh, your vital signs are stable, which is a good thing. It means, that your blood pressure, your heart rate, your temperature are all kind of in a normal range. But when we ask patients in a focus groups, what does stable mean? A variety of, a certain segment of people say stable is where you keep the horses. It's something completely different. We ask people what the word abnormal means. And some people look at the word abnormal and they go, well, it looks like a version of the word normal. It's a type of normal, right? We ask people, or classic examples here around the words positive and negative. In a healthcare context, positive usually means a test result. And for the most part, you don't want your test results to be positive, right? Usually a positive test result is bad. Outside of healthcare, positive is almost always a good thing, right? Positive attitude, whatever. Similarly with negative. Inside a healthcare environment, negative tests are usually what you want, usually good. Outside of healthcare, negative is usually bad, right? So you can start to see how language then can be differently interpreted based on context, based on if I'm a healthcare person or social service personnel who uses this language all the time in one specific way or not. So jargon is a tough one. It's important for us to start to hear it. And I'm gonna skip over this in the interest of time, so we'll have plenty of time for conversation. I'm gonna skip this next slide, which was just a video. We'll move on to the next best practice, which is a tough one. Avoiding information overload. This is really hard, and this is one that I can, speaking as doctors specifically, as a group, we're really notorious for giving too much information at the wrong time and overwhelming people. So, so here's the concern, I guess. There's been lots of studies over decades now that show that the average patient only remembers half, 50% of what's mentioned to them in a, or what's discussed in a medical encounter. Only 50% is remembered, and half of what they remember is incorrect. So what that means is, if I have an office visit with a patient, immediately afterwards, that person's only going to recall about 25% of what we talked about correctly. So for me, I have to be really careful about not providing any kind of excess or extraneous information that's going to clutter up their memory. If I have a couple of important things I want them to remember, I need to give them just those pieces of things to remember and not overwhelm them with other stuff. So, so the way to do that, and this is, we're not going to go through the details of this. This is kind of a strategy that we use with our medical students to teach them how to not overwhelm people with too much information. We start by having them ask the patient what they already know about the issue. Tell me what you already know about high blood pressure, for example. And then we say, resist the urge to talk about all the neat things that you know about high blood pressure, and think about what does this person need to know in order to be successful to take care of this problem. So we can organize the key take-home messages into 3 points. What's your main problem? In this case, your blood pressure is too high. What do you need to do to take care of it? In this case, perhaps it means taking a medication. And why is doing that important? Why lowering your blood pressure can help you not have a heart attack. What's the main problem, what to do about it, and why that's important. And then repeating those at the end and summarizing, which I'm going to show you here in just a second. Summarizing is a really critical task at the end of an encounter, because if you think about what happens in a conversation with a patient or a client, right? We tend to kind of go all over the place, right? We follow the patient's lead on topics and we kind of loop back to topics over and over again. It gets really messy. And patients don't necessarily know how to pull out of those conversations those key messages. What are the most important salient things that they need to remember? They also attend to differences or to topics in unpredictable ways. right? So some of the things you may be talking about might trigger a memory about something that happened to their cousin, and they may really key in on that, even though you thought this was kind of a not, you mentioned something in passing. That might become very important and solidified in the memory of the person where you didn't really intend that to happen. So summarizing helps reorient back to what you think the key messages are. And it gives the person those 1, 2, or 3 main messages that they're going to try to take home. Moving on. So once we've summarized, here's your main problem, here's what to do about it, and here's why I think that's important. We need to say, like, what, figure out if the patient has any clarifying questions, right? And so encouraging questions is our as we're nearing the end of an encounter is important. Typically, however, many of us were taught to ask, hey, do you have any questions? We're almost done here. Do you have any questions? Have I answered all your questions? Something like that. That's a closed-ended phrase that really only has a couple of answers, yes or no, right? And it's psychologically very easy for a person who's feeling a little confused and having a hard time formulating a question to say, I don't have any questions, right? Remember we talked about how patients, when they don't understand, feel a sense of shame, and will try to hide that fact from us. So if a person's sitting there going, this is confusing, they're not going to typically tell us that, and they're not going to say, gosh, I have all these questions, I don't even know where to start. Usually the situation is, no, thank you so much for your time, I don't have any questions, but thank you, and they leave, right? And we know from studies now that they get home, they don't know what to do. So we want to just flip that and open up questions using an open-ended phrase, saying, what questions do you have? What questions do you have, right? It's inviting. It has an assumption behind it that there should be some questions. And the person has to respond in a more than just a one-word yes or no kind of way. So it gives it more opportunity for people to seek clarity. And then lastly, and kind of similarly, we'll talk about teach back before we get into our discussion here. So teach back you may be familiar with, and some of you may already use this. Teach back is really the solution to a lot of the issues that we've been talking about so far. This is a way to know what messages have landed with a patient or not. So the typical way that we see people checking for understanding or checking that they've been clear in their communication is to say something like, okay, so do you understand the plan? Does that make sense? Do we have a good plan? Right? These are closed-ended phrases that many of our colleagues, many of us likely use to sort of check for understanding at the end of an interaction. But again, being closed-ended and remembering that the patients are sort of psychologically motivated to appear as if they understand, most people are going to say, yep, great, good plan, thank you for your time, I appreciate it. Yep, makes sense. And that's it. If we really want to know what's happened in the encounter, we have to use a teach back, which is asking the person to explain it back to you in a way that makes sense to them. So typically we want to say, you know what, I want to make sure that I've done my job correctly or well, and I'd like to check to make sure I've explained things clearly. In your own words, can you explain back to me what I'm recommending today, what the plan is today, right? This is this open-ended, the person needs to say some things. It gives you a great opportunity to find out if they have a safe understanding of the information and a plan to go forward. And if they don't, it gives you the opportunity to quickly correct it. And again, if you're interested, the training video that you've got the link to here shows a demonstration of using a teach back technique toward the end there. There's a 3 or 4 minute section at the end that demonstrates it and then talks about it a little bit. And I invite you to check that out on your own. But for now, I want to just end there, and I'm going to stop sharing slides, and I'm going to open it up for a conversation to hear comments questions, your own experiences, and how we can make all of this work better for our patients and clients moving forward.
We had a couple of questions that were put in the chat as we were talking. One of them came up in regards to the realm and how would you use that in a clinical setting? And I'm not sure if the person who asked that wants to ask a little more in depth. You can unmute yourself and ask.
Yeah, sure. This is Lori Ann Parker Danley. I'm from Nashville, from Vanderbilt. Hello. Yeah, I was just wondering, Dr. Coleman, when you talked about the realm and how it would work in a clinical encounter, and also how would that be different from a screening? Because like you, I'm very dubious of the use of screenings. I feel like, well, if we're using universal health literacy precautions, then that's doing the job that needs to be done aside from the screening. So how do you see realm working in a clinical encounter, and how is that different from a screening, which you mentioned doesn't quite always work well?
Yes. All right. Yeah. Thank you for that comment. So this is a really important topic for me. The realm that I showed you, which was that word pronunciation list, is really a research tool. We use that to because it correlates fairly well with higher level literacy-based skills, and it's a quick and easy thing to use in a research setting. It's not really useful in a clinical environment for a few reasons. Some of those reasons are that patient advocacy groups have said that they don't want to get a literacy test when they come to see their healthcare team. People have said that that's not something that they would find acceptable. But from a more practical standpoint, it's not going to be very useful to us. If I were to try to test a person's health literacy skills when they came to see me in the clinic, I have to keep in mind that those skills are going to go up and down based on what's going on with that person, right? So if you imagine yourself come into a clinic, let's say you're feeling sick, right? And you're nauseated or whatever's going on, you don't feel good, and you've come in to get some help. That's going to be a terrible time for you to try to take some kind of a test, right? Because you're going to be distracted by your symptoms. So your score is going to be low that day. And let's say, so what would I do with that information that day? I don't know. If I try to then put that in your chart and think about a person having low health literacy, the next time you come in for your wellness check, feeling great, your skills are going to be a lot higher. If you're coming in, you're talking to me about something you're scared of, you're worried about, your skills are going to go down. So up and down. So just from a practical standpoint, we don't use any of these screening tools in an environment. And as you already pointed out, it's important to make the assumption that every single one of us, and I'll use myself as the example, can have a hard time tracking information when I'm sick, scared, or hurt. So using that universal precautions approach is the way to do it, and not trying to screen people. And I hope that answered that question. Thank you for that.
Yeah, thank you. That was helpful. Thanks.
Yeah.
We had one other question just for clarification, and then we could get back. You had mentioned some of the links that were in there, but we're not providing the PowerPoint, I believe. Is there a way to get the links that you referenced?
For the video,
Yeah.
let me put it in the discussion. How about that?
Right, that'd be good.
Okay, so let's see if I can get myself out of here. I'll put that link to that training video in the chat.
Perfect. And we had one other comment that I had seen, and I'll see if Chris is still around. If Chris wants to open mic about pronouns in the front line, in the front desk.
Yeah.
Sure. Yeah, I was just going to add to that conversation when we talk about customer service and that front desk person being that first point of contact. With our LGBT folks, it is most difficult to get them into counseling or services, anything related to healthcare, because there's this avoidance of long historical trauma of being mislabeled as having something wrong with them because they're LGBT. So that first point of contact and creating a welcoming environment is so important, because if they have a bad experience, they'll run the other direction. So my comment was about, just adding that, front desk, and even the second point of contact, third point of contact, saying, what pronouns do you prefer? Do you have a preferred name that you go by? It's really important, and I self-identify as a transgender person. All of my legal information says I'm male. All of my health insurance information says I'm male. I present as a male, but I was born biologically female. So I've had a hysterectomy. When I go to the doctor, every single time, whoever's in charge will say, is there a mistake on your health record? It says here you've had a hysterectomy. And it's uncomfortable and it's awkward. And usually I'm outed to a whole bunch of people sitting in the waiting room. And if a transgender person has a bad experience, they won't go back. So it's so important to just make sure that we don't make any assumptions when a person is presenting one way or the other, that that's the pronouns and the gender identity they go with. That's just my comment. Thank you, Karen. And thank you, Cliff.
Yeah, thanks for sharing that, Chris. That's really, really important.
I have something I would ask or say. When you were talking about the video calls with patients, it's really more of a comment, because I see this so much, is that whole lag when you're talking and you don't know when to interrupt, or if you're interrupting, and you mentioned that whole important things can be missed when people are kind of talking on top of each other. And I just sort of wonder if, as we move into the future, is that going to get better, that whole lag thing? Are we going to be able to figure out how to not talk on top of each other in Zoom meetings and any kind of video calls?
Yeah, is it something we can adapt to as people?
Right, and how, right?
I mean, I don't know. I find it really frustrating and unsatisfying, actually, during video visits. And it's weird. I consider myself to be a really good listener, and I make my living thinking about communication. And I personally just find myself stumbling over these interactions by video, for some reason not being able to tell when a person's idea is finished. I wonder if we will all develop some sort of innate skill. I don't think the technology is necessarily going to help us in this sense. I think we're going to have to slow down, maybe. I'm not sure.
It seems like if I've been in smaller groups, or it seems like a lot of college students have gotten pretty used to this, and it really depends on how big the group is. And when you're talking about a one-on-one, it's different, but everybody stays muted. And then when you unmute, it's kind of a signal that you'd like to talk, right? I mean, that feels like the best we can really do right now, or turn your camera on if it's a large group. But yeah, that is always really awkward and leaves me feeling like, oh, what just happened? Was there some flybys because we were talking over top of each other?
Well, it is interesting, like that perhaps the younger generations who've been born into this, the so-called digital native, like generation, like my teenage kids, maybe they don't have any issue with it at all. I don't know. I'll have to ask them.
Oh, looks like Sophia Wong has a question.
Hi there, Dr. Coleman. Really great presentation. I'm just interested to know, do you have any tips on how to prepare patients for specific encounters? So for example, they're complaining about a dermatologic problem that you would need to see or view, how you ask them to prepare so that they're in a proper space and wearing the proper clothes to be able to show that to you comfortably over video. Or, for some of our friends who are doing physiotherapy to make sure that patients have the resources they need, or maybe materials like a chair to hold on to be able to show them exercises that they would need to do at home.
Yeah, thank you, Sophia. That I think it's an area that we that my group hasn't really taken on systematically, which is this idea of really trying to anticipate what the visit's going to be about and how to help prepare the person for it, to take most advantage of it. But some of the ideas like that I mentioned about having the person write down the questions that they have their medications sitting nearby, maybe checking their blood pressure, their weight, or their blood sugar. A lot of those things that can be done up front are likely going to need to be done by the person making the appointment, doing the scheduling, if that's a different person than the person who's going to be having the encounter, right? So this is a team-based approach where we need to work in our teams to have some kind of shared expectations. And your comment about making sure the person's just physically ready for it. Do they have the equipment that they need nearby them? Are they dressed appropriately to do whatever it is that they want to do? I've had a number of visits for people who had skin concerns where it was hard for them to show me because they weren't wearing the right kind of thing. And then we're dealing with this awkwardness of maybe exposing body parts over video, which gets us into this very weird realm that might make me or make them uncomfortable. So trying to anticipate that in advance, for me as a clinician, I'm going to rely on my schedulers for doing that part of it. And that means that we all have to sit down together and kind of have our schedulers maybe doing more creative thinking about this. Unfortunately, they're not trained medically, and so they may not be able to anticipate a lot of the needs that we'd be talking about. But your point is great. Maybe there's a way for us to do some quick kind of triaging or communicating with the person in writing, if their person's logging in through a written, through a patient portal where they can do email with us. And we could send them a quick message about, say we have an appointment coming up tomorrow, make sure you're dressed in comfortable clothes so that we can do some stretching or whatever it is that you're going to do. I like that idea a lot. Yeah.
Are we just jumping in here, or am
Sure.
I inappropriate?
Yeah, go for it.
Hey, Cliff, it's Andrew.
Hi.
How you been?
I'm good.
Good. It's been too long. Give everybody there a hug. I just had to say that.
And Andrew's a really dear old friend of mine. Not that you're old, but that we are old friends.
I'm old. It's all right. You sort of did it, but then you haven't. Tell us what a health literate world would look like in your best, because you've been more honest, because we have known each other for a while. You've been more open and honest in this talk about your clinical experiences than you used. I don't know. Maybe it's because you're just more confident. Anyway, it's different. And I like it a lot. But go ahead and go all the way. Tell people what a health literate world would look like from a clinical perspective.
Wow. Okay.
Yeah. It's also an open door, right?
Yeah. Well, maybe it goes. So Andrew's posing a very almost existential question for this field, and it may be the place to start is looking back at that place where the definition of health literacy kind of diverged, and we have a definition for patients and a definition for health systems agents. And Andrew, I'm sure you have opinions on that, but from a practical standpoint, I think maybe your question is what does it look like from a patient side and what does it look like from a healthcare provider side? And I think those are different. And I'm not sure where you and I have tried for years to find that middle ground where it looks kind of the same in both directions. And I'd be curious to know if what you think it looks like. But for me,
That's no fair. I asked the question.
For me, it's such a grit. I mean, let's do a 90-minute talk on what is this? What should we? What's the world as it should be going to look like? For me, I take it back to really the root problems in U.S. medicine, which is that this is a financially driven enterprise in this country. Not, healthcare is not viewed as a human right in the United States. It's viewed as a commodity, and so our system, the system, as you will, big system, is really incentivized to kind of keep people in the dark, keep patients reliant on us for information. We are the kind of gatekeepers of the knowledge and then the tools that are available to help people achieve wellness and health. And we restrict access to that through things like complex language and difficult to navigate systems and insurance barriers and lots of different ways. So in my perfect world, we would be looking at health services as a human right and not trying to restrict access to it, but make it flow as freely as possible, the information that is. I don't know if any place on earth is doing that, but I'm sure that some people are doing it better than we are.
Yeah, they are. And I don't mean to dominate the conversation, but I'm going to ask a more specific question. FQHCs are the closest that we have in our current medical system to providing care to people who need care the most at the lowest cost.
Agreed.
How would you change the nature of an FQHC?
So federally qualified health centers, where is like a center that I work at, are places designed to, for those of you who aren't familiar with the term, are places designed to provide medical care for essentially for low income folks in our communities. And they have a separate funding system, which in many ways is much better than funding that people might receive through private insurance and private clinics. The model, the FQHC model, from my perspective, provides far better care in many ways than the traditional fee-for-service models that are out there. So if I use my own self as an example, my own insurance is frustrating and puts up barriers to my care all the time. My FQHC patient clients are able to receive really evidence-based care without a lot of barriers. And so I think it's actually, I can imagine a world where we weren't so profit-driven that we could use that FQHC model for everyone. But again, I go back to the fact that, we're in a, with the profit-driven model that we use, people are figuring out ways to extract money all along the way, and by doing so, you're disincentivizing patient engagement and patient understanding. If that makes sense.
Thank you. I was wondering if Chris maybe wanted to unmute and You put a comment in the chat about modeling the expectation of health literacy, the health literacy world. I wonder, do you want to unmute and talk about that a little bit? Looking for Chris. Okay, I guess maybe not.
This is Sally Coletti. I'm from the local Medicaid reform district initiative that we did in New York State. So we can say we did district. Hi, Karen. Hi, Lisa. And I think maybe what Chris is alluding to, as well as Andrew with the FQHCs, is that, you know, through Medicaid reform, you are, and part of the NCQA certification for patient-centered medical homes, meaning a format, you are required to provide health literate services to your patients, clients. You're also required to do integrated care with behavioral health and medicine coming together. And I think CMS directing Medicaid and Medicare in this direction, and having actually been one of the drivers of it, we will go from fee-for-service successfully to something called value-based payment arrangements. In those value-based payment arrangements, providers will be required to provide services for people from head to toe. I always call it head to toe, body and soul. So the entire patient, how are things going? Do you have a refrigerator that works to keep your insulin cold? Not only do you have a ride to the doctor, which we can do, but do you have a ride to go get something my autistic son always says cures a cold: Kleenex, oranges, and Pepsi in a 2-liter. Those are the things he needs. I mean, do you have a place to get, do you have a way to get that? Do you have somebody to come and just sit with you to cure your loneliness? So those are the things I'm sure Dr. Coleman is aware. So I'll be quiet now, but in New York State, we are doing that, and we're pretty successful so far.
Thanks, Sally. That's I think you're right. I do think that's kind of a wave of the future. And we see that here in Oregon as well, that our Medicaid coordinated care organizations are coming around to this this idea of not trying to treat health and healthcare issues in a vacuum, and recognizing that environment and context are really often much more important than what we might be able to offer in a clinical setting. Yeah. Thank you for that.
We had another question.
Hey, this is Chris.
Oh. Go ahead, Chris.
Hey, hi, thanks so much for your presentation. It's been really fascinating. I spent some time in the UK working with social services and primary healthcare services that dealt with mental and physical and learning disabilities. And we ran a program which was called PCP, which was person-centered planning. It's very similar to things that are happening here. And all of the meetings that we ran and that we had for planning included patients or service users or end users. So that at every stage of the process of getting this this health literate world that we're hoping for, they were able to be part of that, so that they could, because it's easy for us to say what we think it would look like, but having them tell us what it needs to look like for them. And so we developed a plan that was a facilitators meeting, so that we were able to train the trainers, so that we had a person-centered planning team that were training other facilitators and other providers and other people who were going to be forward facing. And it was based on the recommendations from those who were going to be at the front end of how that would look for them, and sort of finding out how we can incorporate that so that it's a much more uniformed approach going forward.
Yes, so your notion of, this person-centered planning, it sounds, I think there's the other term that I've heard used for that is patient-centered or person-centered design. And it goes to the idea of having end users in the design process from the very beginning. And it's interesting that it sounds like you've had some good success in that area. We are doing that to variable degrees of success, I would say, in my work areas. For example, at the clinic that I work at, which again is a federally qualified health center, we have a patient advisory panel or committee made up of patient and community volunteers who are not staff at our clinic, but who are potential consumers of healthcare, to help guide us in our decision-making process and our design processes from the very beginning. And I would say that we probably don't utilize that resource as well as we could, and there's some challenges with it. This healthcare system is so complicated and so opaque in the way that the way that it works. It's really hard for outsiders to almost know enough about it to provide useful advice in a timely way when we get together in these meetings. And now what I think we see a lot of the time is our patient advisory panel finding it hard to kind of get a word in or even formulate an idea that they think will be helpful. So there's obviously a lot of room to improve in the way that we make these design processes play out. But I think that ultimately you're right. Like, you got to have users in at the front end at the design before systems get built. But I don't think in where I work haven't figured out how to do that yet.
I agree with. Sorry, Karen. Could I just come back?
Sure.
I agree totally. Some of the challenges we found also was that we ended up having in the meetings, we started to have what we called professional patient advisors. And so they were on a lot of boards, and they were sitting on a lot of panels, and they were directing, and that kind of just derailed the process a little bit, because it came more about what it is they wanted rather than representing the views of maybe a much broader audience. And often when you get a bunch of end users or service users around a table in a meeting like that, inevitably they want to share their experiences, and allowing that to happen, but maybe away from the planning meetings, we found was a really great way to do it. So they had an outlet to be able to have that experience, be heard, and then it could be focused down to what we needed to do at the business end of the planning. So just thought I'd add.
Thank you. Yeah.
Thank you. We had one last one if you have time, and I'll leave that up to you, Dr. Coleman, with your schedule. But there was a question about, could you talk more about patient education with telemedicine other than using TeachBack?
Patient education. Talk about patient education through telemedicine other than using TeachBack. Yeah. Well, that's a very broad question, but sure. The principles around patient education really go back to figuring out what is the piece of information that the person needs right at that moment, and that's very hard to do. And I think I would say most of us working in healthcare are not good at that skill, figuring out what's that critical piece of information that the person needs right then. So I go back to thinking about what does the person already know, and what added piece of information do they need to be successful tonight, when they get home from this encounter, after they've had a busy day at work or a busy day of childcare and they've been distracted. What is it that we need them to remember? And then once you've identified that, which is not easy to necessarily identify, but once you've identified that piece of information, then figuring out what a person's best way of learning that is going to be. And frequently I think we use spoken word only, and we expect people to learn from that. But if you've you know, if you can remember times when you've been in a learning, when you've been a learner in a learning environment, particularly like in a classroom environment, but, you know, most of us don't learn very well from just hearing something, right? In a session like today, you're hearing my voice, but you're also seeing the pictures that I'm showing on the slides. And then we might have a video that helps demonstrate something. And then you may be taking notes, and then you may come back to these slides later to review. And then so there may be many channels or ways of getting information. But we expect people to hear it from us and then have learned it. And that's kind of not realistic. So when we're trying to decide how to teach somebody something, figuring out what their best way to learn is, and oftentimes that means multiple channels. So as I mentioned earlier, it's great to be able to summarize, but maybe you need to provide that in a print format also as a resource later. And you may need to direct a person toward a video that helps illustrate the issue. So I guess I'm going to leave it at that because we're at 9:02.
Yes.
But I'd love to do this all day. But I appreciate everybody's time and showing up to this. It's been great, and I appreciate you having me. Thank you so much.
Thank you. It was wonderful having you.
Thank you, Dr. Coleman.
Thank you.
Everybody
Marvelous.
for coming too.
Marvelous.
All right. Have a great day, everybody.